The labs are getting slowly started right now, so we're going to start with the talks. Dr. Epstein's going to start with a talk about wearable defibrillators, and then we'll take it from there depending on how quickly the labs move along.
Thank you very much. As I'm getting started, I honestly don't know. Do you have the wearable defibrillator in South America, and is it approved or not? Well, this will work out very well because what I'm going to do is to talk about appropriate use of the device and actually give a little introduction to how it works, and I hope you enjoy this. So in the United States, the criteria for prescribing the wearable defibrillator, and I'll show you how it works in a moment, is in the waiting period that I talked about yesterday, post-infarction, in patients with non-ischemic cardiomyopathy undergoing the optimized medical therapy for waiting for 3 months. And then in certain situations when defibrillators are extracted for infection and you're waiting for it to heal, or trying to make a decision about whether or not somebody's getting a defibrillator. And then finally, there's an indication that I don't quite understand, which is before transplantation, if you have class 4 heart failure, you can prescribe the device and get paid. So today's focus, I'm going to talk about the waiting periods and the data about the efficacy of the wearable defibrillator during them. I'm going to talk about how the device works, and then show you some clinical trial data in this. So this is a slide that I showed yesterday in one iteration. Why is there the waiting period? We want to see whether or not the substrate is going to improve, the responses to therapy. When heart failure, for example, is newly diagnosed, we don't know how LV function may change. We know that defibrillators are not useful in the early post-infarction period or after the initial diagnosis of heart failure. But are there some patients, and I'm going to keep using this word again and again and again, who have a perceived higher risk than usual for whom the device may be worthwhile? And then there's always the question of reimbursement. We do not get reimbursed if we implant a defibrillator too early. So this is just to recall that during the waiting period after myocardial infarction, there is no proven benefit of an implantable defibrillator. And this again shows that the LV function can markedly improve in more than 50% of patients to achieve ejection fractions that exceed the criterion for ICD implantation if optimal medical therapy is provided. And then similarly for non-ischemic cardiomyopathy, with optimized medical therapy, the left ventricular function can improve. So what can be done during the waiting period? We've talked about medical therapy. There's a role for risk stratification and monitoring, perhaps, but a patient may still be at risk for sudden death. Studies have been done in the United States deploying external defibrillators for the home, which have been miserable failures, actually. Not only do family members freeze when a family member arrests, but many arrests are unwitnessed and the device can't be used. And then finally, there's the wearable defibrillator, wearable cardioverter defibrillator, or the WCD as it's called. The way this device works is it has self-gelling electrodes that deploy. There are no electrodes that need to be stuck on. It's lightweight, easy to wear. The patient is able to inhibit a shock actually by pressing a response button on the belt of the device if they remain awake. It delivers 150 joule shocks, captures 30 seconds of the electrocardiogram before the event, and can store up to 75 minutes of electrocardiographic recording. So this is where the device can actually work for risk stratification to look for sustained but spontaneously terminating ventricular arrhythmias, for example, during the waiting period. This is what the device looks like. There's this vest with the purple being electrodes. Again, I don't have the pointer that works. And if ventricular arrhythmia is detected, gel is deployed, and then the device can give a shock. The way this works is the electrodes are depicted there with those arrows. The self-gelling defibrillation electrodes are on the back. The response button that I mentioned is easily accessible to patients that they can inhibit a shock. And then, as I said, it can function as a monitor, delivered shock, and store electrocardiograms for the events. The duration of the arrhythmia before therapy is given is just short of a minute. I'm going to show you that in a moment. When an arrhythmia is detected, patient is alerted with a vibration, then it actually makes a sound like a siren. The siren gets louder. It then tells the individual that an electrical shock is possible. The gel is released. There's an audible bystander prompt that says, "Don't touch the patient," and then the shock is given. This is an example of the treatment of both ventricular tachycardia and ventricular fibrillation. As I said, it's just short of a minute, about between 40 and 50 seconds from the time of diagnosis to the delivery of a shock. So how does this thing work, and how does it perform in the community? This is an article from Mina Chung at the Cleveland Clinic examining 3,500 patients in a database. Of the people who died, there were 23 who had a systole. And as you know, that the results of resuscitation of asystolic cardiac arrest are miserable, as it was in this study. There were 3 patients for whom there were no recorded events that died. But of 59 patients who had ADVT events, there were 8 deaths. 4 were for repetitive VT. 1 was where the bystander listened to the prompt and inhibited the delivery of therapy. That might have been an unhappy spouse. There were 2 where the ECG signal was disrupted in the fall, and 1 actually with a unipolar pacemaker that inhibited therapy. And we don't talk about this much in the current age of implantable defibrillators, but back in the day when defibrillators did not have pacing, we'd implant both devices at the same time. What happens is during ventricular fibrillation, implantable defibrillators are looking for the smallest signals. And if there's a unipolar pacing spike, it will see that spike as a sinus beat. And the wearable defibrillator can behave in the same ways. One of the concerns that many have had about this wearable device is discomfort and whether or not patients will tolerate it. And in fact, the wear time, as it's called, is a mean of 22.5 hours in virtually all the studies that have been done. And it's really quite well tolerated by the majority of patients. Now, there are individuals that you'll see who do not like wearing it and will ask to have it taken off, but by and large, it's very well tolerated. Well, let's take a look at a number of studies that have been done in terms of the utility of using this. And I want to emphasize again that to date, there has been no prospective randomized trial that has looked at the utility of the WCD during waiting periods or at any other time. So all of these are retrospective analyses from databases. This is a study that I looked at because I was interested from a guideline standpoint, where the Zoll company that makes the defibrillator was kind enough to give me information from their database of over 8,000 patients who were given the device with a primary diagnosis of post-myocardial infarction. There were 1.6% of the patients who received an appropriate shock. 1.4% were successfully treated. The ejection fraction of those treated was 23%. The median time to the shock was 11 days. And the 1-year survival of all patients was 93%, and in fact 65% of those who were shocked. Now, the problem with a study like this and all that are there is you have to ask, why did this person get the device? And these were individuals who were perceived to be at high risk by their physician. And I'm going to end up with a patient example to tell you what that means. I do not think that the wearable defibrillator should be everybody, but there are certain individuals that you feel uncomfortable with, for example, with non-sustained arrhythmias, where it might be a very a reasonable choice. This is highlighting the problem of just post-PCI. And remember, after revascularization is done, whether it be at the time of infarction or otherwise, there's a 90-day waiting period before reevaluation of the ejection fraction. And this just shows you that there's a very important risk of mortality post-PCI. And many interventionalists in the United States are worried about this in terms of how they appear on national registries for their mortality after doing a procedure, or their mortality scores after doing a procedure. And so there's an interest of using the vest post-revascularization. And again, from the Cleveland Clinic, there's a paper that examines the utility of the WCD post-revascularization. It looked at PCI, and in the next slide, I'll show you the results after coronary bypass grafting. Interestingly, there is an 85% lower mortality at 3 months. The problem that I have with this study is, why would a device that is worn for 3 months continue to provide improvement out to 3 years? And what that tells me, that this is a highly select group of patients, that is, individuals who are perceived to be at high risk, who got the device. But for those individuals, it provided benefit. Same kinds of slide is shown for the post-coronary bypass patients, 58% lower mortality at 3 months. So again, those individuals who got the device for perceived high risk seem to benefit. So that's coronary disease. What about the non-ischemic population? And there's very little information about this, but it was the group from Pittsburgh has just published this last year, and I think it's very important and useful. They looked at 525 patients with newly diagnosed cardiomyopathy. About half of them had ischemic cardiomyopathy on the red on the left, and 254 had non-ischemic cardiomyopathies. Look at this. For the ischemics, there was a 2.2% appropriate use rate with an effectiveness rate, that is people leaving the hospital, of 1.3%. That is virtually identical to the 1.4% that I showed you from my study before. So it seems that there's some consistency in the data. What's most interesting to me, however, is on the right side, that of the same number of patients with newly diagnosed non-ischemic cardiomyopathy, there was a 0% usage rate. Now, as I've listed over on the right side there's certain things that we can say to modulate any conclusions about this study. Number one is that all patients with ischemic cardiomyopathy and appropriate shocks were male with long QRS durations. So in retrospect, maybe that would be a group of individuals, especially with non-sustained arrhythmias, who might be good candidates. All of these patients were recruited when they were hospitalized. And so that is a particularly high-risk group of patients. And these data may not apply to folks that you see in clinic. But that being said, if people in clinic are at lower risk, then you'd expect even lower usage rates. There's no denominator. And then finally, a zero risk in a small study does not mean that there's no risk at all. But still, I think we can take away from this that the risk is small for the non-ischemics. So the conclusions of the authors were that the risk is minimal for patients with newly diagnosed cardiomyopathy. The wearable defibrillator for newly diagnosed patients with ischemic cardiomyopathy is reasonable, but we need more information about the non-ischemics. Just to finish up, another group of patients where it makes a lot of sense to use the device are those who are awaiting reimplantation of a device that's been taken out. This just highlights the cost effectiveness of doing this. If you are waiting for an infected individual to heal who's not pacemaker dependent, to let them go home for 3 weeks with the wearable defibrillator not only makes scientific sense, but also great economic sense that you don't have to keep them in the hospital. So where we are now is the manufacturer is in the midst of a study called VEST, which is the wearable defibrillator, the VEST prevention and early sudden death trial. The hypothesis is that the device will reduce sudden cardiac death in the first 90 days after MI in patients with low ejection fractions, and they have a registry for follow-up. The entry criteria are pretty well as what you'd expect, that if there's no PCI or PCI, you can in fact enroll people as short as 8 hours after the intervention. And if CABG is planned before within 7 days of discharge, you have to wait until 48 hours after that type of revascularization. The target enrollment is 1,900 patients. The estimated completion date was November 2015. This is actually being the PI for this is in California. Enrollment is slow, so it's been extended, and we do not yet have the results. So to conclude, the wearable defibrillator can protect patients in the period excluded in clinical trials before ICD implantation. It's got a very high success rate, over 95% for resuscitating cardiac arrest, and more than 90% of people with shocks can be discharged from the hospital alive. There's a very high compliance rate, and as I said, it's optimally used in patients perceived to be at especially high risk and after extraction. So who might an individual like that be? This is a patient who is in his 50s. I took care of a couple of years ago. It's now actually been published. This patient presented with a cardiac arrest at an art fair. He was brought to the emergency room, cooled. He was fixed and dilated with no cerebral function, but taken in accordance with many of our standards immediately to the cath lab. Had single vessel right coronary disease, was occluded, opened, and his ejection fraction thereafter was 45%. He awoke the next day, and on day 4, on the day of planned discharge, he had this rhythm. Now, to me, it's worrisome. It's perceived high risk. You think that at that ejection fraction in this early post-infarction, which is outside the 48 hours that I talked about yesterday, might qualify him for a defibrillator, but it's not 30 seconds. It's accelerating, so it's probably automatic. So this guy we gave a vest to. He never used it. At 1 month, his ejection fraction was 55%. We took off the vest, and he remained alive when I left Alabama a number of years ago. But this is the kind of perceived high risk that I think is reasonable. The Heart Rhythm Society has an algorithm for us to deploy this device, and you'll see below the green line there for the groups of patients that I've spoken about. They do have consider combination or consultation with a heart rhythm specialist, or consider the wearable cardioverter defibrillator. So I hope that that's a worthwhile summary of use of this device and where it can and might most appropriately be used. Thank you. Yeah, just bring your mic.
Very nice talk. Just
Thank
two
you.
quick questions. How many shocks is the device capable of delivering?
I think the newest version, it can give 4.
4.
I think so.
4 shocks.
It's more than 1.
Okay. And in practical terms, the patient must wear this device 24 hours a day. They remove for sleep, for shower. How do you orient the patients?
The 22 and a half hours takes into account taking it off for taking a shower, but most people wear it when they go to bed.
Okay. And it's not uncomfortable for
No.
them. They do not
The
complain.
newest version is much smaller than the versions over the last couple of years. It's the straps are very small.
Okay, thank you.
Any other questions?
You already told me yesterday what you thought about EP study, but there is data that inducing monomorphic sustained ventricular tachycardia before sending them home differentiates a higher risk patients with a wearable defibrillator. I'm sorry to insist, but the mechanism assume a rhythmic substrate because you have induced monomorphic sustained VT, not just what other rhythms, just monomorphic sustained.
As we've talked, I think you tilt towards doing EP studies, and I just the biological reasonableness of having a fixed substrate that's not going to heal, it just is hard for me to accept, and that's me. Now, that being said, for the patient that I showed you, I think that even though it's monomorphic, the acceleration of the rhythm really tells me that it's a focus that's automatic and that this very well may heal. And that's why I went that way with this patient.
Looked like maybe it could have been fascicular, just but we only had a single lead, but it had a really abrupt onset and a superior axis. Maybe it was some fascicular activity post.
Who knows?
Okay, if there's no additional questions, because Dr. Epstein has a second talk, we'll let him go ahead with the second talk, change the schedule around a little bit while we await hearing from the lab about the progress on the cases.
Yeah, apparently they were just beginning to prep, you said, for the cases this afternoon. My second charge for this afternoon is to talk about leadless pacing systems, and I think this is really a lot of fun because I think I'm going to show you that there are many new opportunities here. When I started doing defibrillators actually in 1982. We did the 36th implantable defibrillator in the history of this technology. These devices were huge. They were 55 grams. They were big. They had to be implanted with a thoracotomy and in the belly. And now we're down to these tiny things that are order of a small number of grams, small size, and we have loop recorders even, and what I'll show you now, transvenous pacemakers that are just 2 grams that can pace. So devices are tremendously different. So why are we talking about leadless pacing systems? And that's probably because of our disillusionment with transvenous leads. Complications, at least over time, can occur in 10% of patients or more. Certainly early on in the first month, there's a risk of lead perforation, dislodgement, pneumothorax, vein thrombosis. Younger patients, as we know, especially from the Fidelis database, at least for defibrillator leads, have a higher risk for fracture because of their activity. This is probably true for pacing leads also. There's the risk for infection and lead extraction, as Dr. Carrillo showed you yesterday with leads becoming adhered to the endovascular system. There are 3 leadless pacing systems that are either approved now for general use or in clinical trials. There's the Boston Scientific system on the left, which right now has begun clinical trials in Europe, being married to the subcutaneous implantable defibrillator. And in the United States, we have approval of the Medtronic Micra system and the St. Jude NANOSTIM. These are sort of a list of the characteristics of the devices. They're more similar than different, but the important point is they have battery lives that are certainly greater than 5 years, if not 7, and they're all implanted in much the same way as I'll show you. The principle here is that these are small devices that can be implanted now in the right ventricle, usually at the apex and on the septum. They have a similar longevity and functionality with accelerometer-based rate response and automatic pacing capture management, just as do transvenous defibrillators nowadays. The way that the device is put in, and I'm going to show you in a movie in a moment, there are tines that you'll see that come out through a sheath. They get exposed, you tug on them, and then the device stays here at the right ventricular apex. The tines are part of the Medtronic system. The St. Jude system actually has a helix, and it screws into the subendocardium. You can see how small it is there compared to a single euro coin. These devices actually are MRI compatible. They're designed for retrievability, which I'll show you in just a moment, but I think that's one of the big uncertainties of these devices, how easy they're going to be to get out. This is the Boston Scientific device, and like the Medtronic device, it's got these tines, or little hooks that are in the end that attach to the endocardium of the right ventricular trabeculations to hold it in. As it says in the last line there, pairing the leadless device with a subcutaneous defibrillator may provide pacing capabilities for people with that device. This is how the device is put in. And this is a cartoon showing that there's a sheath that goes to the right atrium. It's deflected into the right ventricle. You'll see tines coming out there, going into the myocardium. And now the sheath will be pulled back, and there are these sutures that you tug on to make sure that the device stays in the endocardium. When you are sure that the device is well secured, the tether is cut, pulled back, the catheter is retracted and pulled out, and you are done. The time for implantation is, after you've done a few of these, really gets down to about 10 minutes. It's really remarkable how quickly it can go. The success rate and the location is well over 99%. Virtually all of them go at the apex or at the apical septum. It didn't show up in the slide, but there's about 1% that get put on the free wall and higher up on the septum, but that's unusual. Although it was, the median time to implant was 28 minutes in the clinical trials, it really comes down to 10 minutes when you get good at this. In terms of the complication rate, and this is one of the problems with the device and for getting approval through the Food and Drug Administration, it really was ranged anywhere from 4 to 10% in the different studies. There were a number of perforations early on, but with the redesign of the sheath and the flexibility of the sheath, that particular complication has diminished to on the order of 1%. The performance of these leads are very much like steroid-eluting leads that we're used to. There's stability of the R-wave amplitude. In fact, in the Micra study, it grew a little bit, but 16.4 millivolts is nothing to be unhappy about. The pacing lead impedance is stable. And importantly, the pacing threshold remains particularly low, and with capture management, based on the use conditions of 300 patients in this study with 6-month data, the median battery longevity estimate was 12.5 years. I have never in my career seen estimated longevities really be lived up to in real life, but even if it gets to 7 or 8 years, I think it'll be pretty good. Now, what about retrieving the devices? All of the companies have developed platforms to do this. For the Micra, there's this little button at the end, and there's a snare that they've developed that can go around this. It's just like the snare that we use for extractions, and you can put it around this button and pull, and the device will come out. Remember, these tines that hold it in are very, very small and deflectable, so if there's not scar, you should be able to pull them out. St. Jude has got a similar kind of device. Since this is a helical screw, you can't, there's nothing to bend. There's obviously the risk of pulling some myocardium, but there's a snare also that can go around the docking button, as they call it, to pull it back. It's a large French sleeve to put this in. It's 18 French, but the vein, as we know from the other stuff that we do, the femoral vein can tolerate that pretty well. Here's an example of a lead retrieval that Mark Miller has presented from Sinai in New York. There's this snare that goes around the button. It is secured to the docking port, and then it's withdrawn into the sheath, and the whole sheath is pulled back. Now, this is where I have concerns. And just because there's not a lead that's in the subclavian vein or in the superior vena cava doesn't mean that it's not going to get infected. This is showing at a canine chronic study. Look at the scar that is developed around that device. I think you'd be hard-pressed to either get a snare around the button or to pull this thing out. And here's another study on the bottom showing how this device can get invaginated into the tissue there. And I think that this may be very, very hard to pull out. One of the more worrisome things that I've seen is that this is a device that was implanted, I think it was just short of 3 years, if I remember from the article. Look at the scar that is around that device on the left there. I don't think you're going to be able to get that out. Well, what happens if you put this in a young person and you want to get it out when you want to put in a new one? How many can be tolerated? The RV can tolerate up to 3 of these in this study that was literally just published a couple months ago. I don't know if I want that much stuff sitting in my right ventricle. Huh? Size, because the right ventricle is flat, and they just tried to see how many they could get in. It's not like an electrical interaction. No. It's a real estate. The question is what defines tolerable, and it was a assessment of how much real estate was available to accommodate that much hardware in the right ventricle. And just moving on to where the technology is going, Boston Scientific is marrying, as I said, the leadless pacing system with the subcutaneous defibrillator, and to avoid endovascular hardware. I hit the wrong one. Here we go. And this is the first reported study showing how antitachycardia pacing can actually occur. This was in a animal model, but you can see both the leadless pacemaker as well as the subcutaneous defibrillator and a simulated ventricular tachycardia with antitachycardia pacing. So I think this is going to be the next step that we'll have in the United States. This is undergoing clinical trials in Europe already. And then finally, what about left ventricular pacing? The EBR system, as it's called, is really a novel idea. It is providing a leadless pacing solution, they like to call it, for biventricular pacing. It's an endocardial pod that gets put in, and you can actually move through their introducer sheath to different spots in the left ventricle to find a spot that is appropriate. The size of this device, as you can see in the individual's hand there, it is literally less than a centimeter long, and it's covered by this mesh where scar grows over it into the left ventricle. There is a ultrasound transmitter, which is used for both providing energy, the electrical energy for the device to work, as well as for communication. This device is designed to communicate with right ventricular pacing leads and typical standard dual chamber pacers to provide left ventricular pacing. This is just a cartoon showing how the ultrasound energy is transmitted, and this is an example of the implantation with a retrograde aortic approach being put high on the left lateral, lateral left ventricle for biventricular pacing. So to summarize where we are with leadless systems, right now we are already doing single chamber pacing. There are systems being developed to be able to put pods in both the right atrium as well as the right ventricle. On the lower left is combining with a subcutaneous defibrillator, and then I just showed you the left ventricular, biventricular pacing system, which is in development. So I think these implantable devices have a really promising future and added clinical benefit by avoiding transvenous leads. I think the new designs, though, are going to present some real new challenges, and I still worry about infection, even if it's localized, and how we're going to get these things out. So with that, I'll finish, and hope I've kept on time. Thank you. The question is cost. It's expensive. And as with everything, the list price is not what hospitals pay. And in terms of what we pay, we have a arrangement where our hospital prevents us from knowing actually how much things cost. It's a totally bizarre situation at the University of Pennsylvania, but we do not know how much the stuff costs that we implant.
What is
it's about $10,000, I think. Maybe $8,000 to $10,000 for the right ventricular transvenous pacing system.
I know they're expensive because we were supposed to be part of the St. Jude trial, but the reimbursement for what they were costing did not match up in the hospital.
It's between $8,000 and $10,000.
Just one quick question. The timeline for dual chamber systems, do you have any sense of that? Because the majority of our patients don't have chronic AFib, and so the single chamber devices are a very small percentage of our pacing business.
I have absolutely no idea on the timeline of that. I will say that, a patient population that might be particularly good for dialysis patients, for example, and we worry about that with implantable defibrillators. We worry about it with pacemakers. There's a high incidence of AF in those individuals, so that may be a special need population for which it'd be real good.
Who is implanting these devices in the U.S.? EP guys or interventional cardiologists or both?
It's virtually all EP.
Would you consider anticoagulation for the left ventricular device, or just dual antiplatelet therapy until it gets endothelized?
I haven't seen the protocol regarding anticoagulation. I think they do it for a couple of months. It endothelializes very quickly, though.
I used to work in Leipzig. I'm going to do it again in next year. And we have experience with NANOSTIM. Yeah? We were putting this device. We didn't have actually much troubles. That was like 3 years ago, but we stopped doing it because in Hamburg, 2 people died. In the same month, 2 people died in other countries in Europe. So they stopped the study. Yeah, most of the people know that, it doesn't know that.
Yeah, I think that was, again, early in the experience.
The people should know it because
perforation.
I heard from other guys talking about that and saying, no one died. You say, sorry, man, I know for sure that 4 guys died. And most of the guys who make implantation doesn't have people who died because of that. Yeah. I don't know if you knew about that or...
Yeah. As I said, perforation was an important problem earlier in the trials, and the risk is much decreased with the new sheath technology. Thank you very much. And again, I've really enjoyed being here, and thank everybody for your hospitality.